Good morning, everybody. It's Saturday, sort of wrapping up the lecture and the sessions for today. Appreciate everybody for being here this morning. We have a very distinguished panel here today. My co-moderator here, Dr. Maier, is also here to help guide us through. I think how this works, some of y'all have been to some of the lectures, but I believe we will give a lecture. At the end of that lecture, there is time built in for discussion or questions, and then we'll move on to the next. So I think that's how we'll handle it. Great, excellent.
All right, thanks, Brian. I think I'm going to come down and grab the clicker here. All right, so I want to compliment everyone for making it early on a Saturday morning. So what better thing to talk about than wounds on a Saturday morning? Anyhow, we'll go ahead and get started with a brief case, a case of complex PAD with pedal ulceration. So my name is Mike Maier. I work at the Cleveland Clinic in the section of vascular medicine. So in any case, let's see. Can one of you guys give me assistance? It's not advancing. There we go. Let's see. I don't have any disclosures. So, briefly, a 71-year-old diabetic gentleman presented with painful fourth and fifth digits on the right foot in the setting of known peripheral artery disease and dense peripheral neuropathy. So the first red flag was pain in the setting of neuropathy. In terms of his relevant cardiovascular history, he certainly had had previous intervention with successful drug-coated balloon and stenting of the distal SFA to popliteal artery only 8 months prior, but in that case was for the treatment of acute ischemic rest pain in the right foot. So he didn't have any tissue loss at the time, but definitely had rest pain. He had resolution of his rest pain following that intervention, but thereafter had known AT artery occlusion with 2-vessel runoff to the foot, so no tissue loss at that time. But unfortunately, some months later, due to ill-fitting shoe gear, he presented with ulcers on the fourth and fifth toes with this appearance. So fairly classic in terms of arterial disease, well circumscribed over bony prominences. And you can see some erythematous discoloration in the fourth digit, to a lesser extent in the fifth toe. The interesting thing here is trying to differentiate between infection and ischemia, or both. And what we found was when he elevated that limb, there was some pallor to the digits and independency, more dependent rubor, so suggestive of arterial disease. Also at the time, he was admitted and he had updated PVRs, and you can see the study on the right-hand side. The study doesn't look all that bad, and if you look at the numbers, actually, he has normal ABIs and pulsatile tracings all the way to the digital level with no significant difference from one limb to the other. Additionally, he had arterial ultrasound and found to have patent stent in the SFA and popliteal arteries. So everything from a non-invasive perspective looked pretty good. So he was treated with IV antibiotics for soft tissue infection, and at the time seen by the vascular surgeon on call in the hospital. And the surgeon recommended no intervention based on normal ABIs, pulsatile tracings, and no ischemic rest pain, and recommended a conservative wound care approach. So this was the challenge, this patient with tissue loss, known recurrent occlusive disease. So he came to see me after hospitalization with actually worsening ulcers and worsening pain in the foot. So we involved the interventionalist in my group, and he did an anterior tibial artery angioplasty and stent via retrograde pedal access with resultant 3-vessel runoff to the foot. In addition, we performed meticulous local wound care with both enzymatic and sharp debridement, appropriate offloading footwear, obviously that was the primary insult in the first place, and then aggressive medical management for risk factor modification. And you can see over the course of about 6 weeks, he had gradual improvement and, in fact, complete epithelialization. In that middle picture, you do see he has some focal dermatitis, which we treated with a topical corticosteroid. But in addition to epithelializing the toes, he also had resolution of his discomfort. So in terms of learning objectives and take-home messaging, when it comes to treating pedal ulceration in the setting of multi-level disease, PVRs and ABIs alone are inadequate for perfusion assessment, certainly in the diabetic patient. Because of that presence of neuropathy, it's very difficult to differentiate between pain due to neuropathy, infection, or otherwise. And I put this statement here that the physical exam is king. Regardless of any imaging, be it non-invasive or otherwise, the physical exam is, in my opinion, the most important thing. Additionally, and some would argue, an angiosome-based approach to perfusion optimization maximizes healing potential for pedal ulceration. So in this situation, the patient had tissue loss on the dorsal aspect of fourth and fifth toes. in both the AT and perineal angiosome, some overlap there. So it was felt that direct reperfusion specific to that area of tissue loss would optimize his healing potential. And then finally, I think it goes without saying that good wound care demands comprehensive patient management. So that's the case. Any questions or comments for this? And I'd also direct that to the panel, perhaps. Thoughts in terms of maybe approaching this differently or otherwise?
I'll chime in. I think it's a great case and very concise. Would you feel, now that the patient's been optimized, that there's an opportunity for a prophylactic procedure to sort of prevent recurrence, such as, flexure tenotomies or arthroplasties of those digits to prevent issues down the road?
Yeah, it's a great question. When it comes to doing surgery in the diabetic foot, certainly we can think about doing things in a therapeutic way or prophylactically. In this situation, unfortunately, this gentleman has a long history of poor glycemic control, poor compliance with follow-up. So, and additionally, other cardiovascular risk factors, uncontrolled hypertension, hyperlipidemia. So probably not an ideal surgical candidate. If he was more compliant, perhaps such. But we got him into the appropriate orthotics and then accommodative footwear. For non-podiatrists in the audience, you can do things like shoes with neoprene uppers, so it's a seamless interior, and reduce the risk of recurrence of those types of wounds. The short term, actually, in terms of offloading, I think some of the easiest things you can do instead of trying to get prescriptive footwear is have him take a narrow pair of tennis shoes and literally cut a hole in it. It's an effective way to get pressure off that area of tissue loss. But for long term, he was not a surgical candidate. It's a great question, Brian.
I have a question. So many times patients present with the dense peripheral neuropathy, and in the current guidelines, unless they have a wound, there is no recommendation to revascularize below knee arteries. And I have actually one patient could not walk, and I told him I'm going to bite the bullet and revascularize, and he started walking. So it could be an anecdotal case, but my question to the panel, Kolluri, and you guys see these patients more. How often you see the classification of neuropathy as arterial disease?
Well, that's really a great question in terms of, is it primary neuropathy that's causing it, or it's a neuroischemic ulceration? In my talk, I'll have a slide you'll see where even in a randomized controlled trial of below-knee interventions, live BTK, there were a significant amount of wounds that are enrolled as ischemic wounds when they clearly were neurotrophic or venous, which means that, yes, there was below-knee disease, but the wound appearance is something else. And if you dive deep into the Rutherford classification, it just talks about tissue loss. It doesn't clearly say what type of ulcer there should be. Yeah, so that's one of the downsides, I suppose, of the Rutherford classification. So we'll hear more about the WIFI classification too. But yes, the simple answer to your question is it's always in the back of my mind when I'm treating these patients in the wound center.
Yeah, it's a very insightful question, agreed. In fact, that was part of the decision-making process for this patient. He actually had pain, but specific to those digits. So I think that would be unusual to have neuropathic pain specific to the area of tissue loss. That's what prompted us to intervene and try to revascularize specific to that angiosome. But very difficult and a very insightful question. Anybody else from the audience? Okay. So we're going to move ahead then with our next presenter, I think. There we go. So next we'll call up my good friend and colleague, Dr. Teresa Carman. Dr. Carman is the the Director of Vascular Medicine at University Hospital's Harrington Heart and Vascular Institute and an accomplished speaker and physician. Dr. Carman.
Thanks, Dr. Maier. Thanks again to the organizers for the opportunity to be here on a bright Saturday morning. So we're going to talk about a non-healing venous wound. And I don't have any disclosures relative to this. So the case is that of an 86-year-old lady who presents with a left lower extremity ulcer, reports that this has been present for about 6 months. She's been seen by another local wound clinic and has had very little improvement in the ulcer since that time, or during that time. She has typical cardiovascular risk factors, diabetes, hypertension, hyperlipidemia. She denies any symptoms of claudication. She lives alone, and she currently sleeps in a recliner. So when we talk about non-healing ulcers, or when we talk about ulcer healing in general, what we have to realize is that while about 1 in 5 ulcers heals in a typical 3-month period, more than half take over a year, 20% may take up to 2 years, and 10% are considered recalcitrant. So while wound healing is always our goal, we do have to realize that sometimes ulcers don't heal the way we expect them to. With that being said, there are certain things we have to do to make sure we are doing all we can for these patients. The first is having an accurate diagnosis. So we have to make sure that this is really a venous wound, right? It could be other things. It could be related to underlying collagen vascular disease, it could be related to an underlying malignancy, or there could be malignancy in the base. This doesn't look typical for pyoderma, but on venous ulcer, certainly should be in that differential. So one of the things we have to make sure is, are we really dealing with a venous wound? And then we approach our clinical challenge of a non-healing venous ulcer and say, what else keeps us from healing? Well, from a vascular standpoint, you have an 86-year-old lady with multiple vascular risk factors. We have to make sure we understand whether or not she has any peripheral arterial disease, and then make sure we've looked for any venous disease. We have to control edema. It sounds to date like she has had fairly inadequate compression. She sleeps in a chair, so we have chronic dependency, and we have to make sure that she's using her calf muscle pump function. You can see that there was a lot of erythema, so we have some inflammatory changes. There's a poor, unhealthy wound base. We have to make sure there are no other confounding medications. And then we have to talk about substrate. Malnutrition, particularly in our elderly population, whether or not they live in a food desert, is a very common source of poor wound healing, poor social support, etc. So we do have guidelines, and patients should have arterial testing, even in the setting of a presumed venous wound. So we need to make sure we get these patients to the vascular lab. Past that point, we need to make sure from a venous standpoint, we at least have a roadmap of what's going on, and we know whether or not she has changes consistent with reflux or obstruction or other components of chronic venous hypertension that may be keeping us from healing. Edema management is a must in these patients, and it's frankly fairly underutilized. Now, the ideal is a 30 to 40 millimeters mercury of compression. That's probably not practical in an 86-year-old lady. But I do think that you have to do all you can do to manage the edema. You also have to be respectful of an abnormal ABI. So if she has an ABI less than 0.6, you probably have to be very, very, very cautious, and maybe not the best to compress in most people's hands without getting that revascularization first. We have a lot of different tools that we can use. We use these differently in different patient populations, and being familiar with all the tools is very important. And passive decongestion can't be overestimated. So we like to get these folks into bed, get the foot of the bed elevated, get that venous hypertension offloaded overnight, get them out of the recliner, keep them from sleeping in the chair. When wounds get stuck, they almost always get stuck in the inflammatory phase. Now, the inflammatory phase is very important as that one of those initial phases of wound healing. It allows us to clean up the bed, bring in monocytes, macrophages, and helps us prepare the bed. But when we get stuck in the inflammatory phase, we have to step back and say, why are we stuck? Most often, that's going to be a situation of colonization. Maybe not true infection, but colonization. The bed may be unhealthy, we may not have been adequately debrided, we may have that ongoing venous hypertension, and then we have to think about other drugs and things that may keep us in that inflammatory phase. We clearly have inflammation. With the patient that I showed you, we have a lot of dermatitis, there's erythema, you can see that that skin is very irritated. But even if you look at the wound on the right-hand side, where we don't have that same erythema, we still have a very unhealthy base and very unhealthy wound edges. This is also an inflammatory complication or inflammatory change in this base, and until we get that to a nice, healthy granulation tissue, that wound is also not going to move very well for us. Nutrition can't be underestimated, and nutritional supplements and support is imperative. I tell all of my patients I like to have them have about 125 grams of protein. Now that's a big number, but if at least they're striving for that, I think it helps. And I tell them protein with every meal, protein with every snack, so that we can get additional support on board. And then we have to look at imaging. So for Our Lady, we didn't have any DVT, we didn't have any chronic changes, but we did have a perforator in the area of this wound. And perforator or isolated perforator reflux certainly is going to keep that wound in an inflamed state. It's going to keep that wound from healing, and we need to get that taken care of. Her ABI was 0.6, but she had an adequate toe pressure of about 75 millimeters of mercury. So I think with awareness in our use of compression and management of the venous disease and management of her comorbidities, we'll probably be okay. So how did we take care of this? Well, we sent her for consideration of the perforator management and also that subulcer venous plexus, because I think it's very important to get both of those addressed to get rid of that venous hypertension. We put her in a gentle multi-layer compression and support from home health care for weekly wound management. But you have to really keep an eye on these folks. Get her into bed, elevate the foot of the bed, gentle debridement, biofilm management, very important, and then nutritional support. And with that, we can usually get them to healing. Now, one of the considerations that I want to leave you with before I finish is the use of micronized pyranide flavonoid fraction and or pentoxifylline in these patients with difficult to heal wounds. And you can see that this carries a fairly high level of recommendations from all of our major vascular societies. And certainly it is one of the considerations in these individuals. I don't think it's necessarily necessary for everybody, but it certainly can help with that inflammatory state and can help with wound healing. So our key learning objectives in these patients with difficult to heal wounds: make sure you have an awareness and an understanding of what their arterial state is as well as their venous state. You have to control compression with, or control edema with compression and elevation and manage all of those underlying comorbidities. And then most importantly, it's usually that inflammatory state, and we have to manage the inflammation, debridement, nutritional support, compression, et cetera. With that, I thank you for your attention.
Great job. Thank you very much for that. Any questions from the audience and or the panel, please?
Yeah, Terry, great talk. You have a patient with ABI of 0.6, and you talked about gentle compression therapy. What is your threshold, if there is one, for an ABI where you would recommend intervention for the arteries before you compress? Is there a recommendation? But there's no guideline for it. But
there's no guideline. Anything below 0.5 makes me very nervous, even in my hands and even in my nurse's hands. Yeah. And I think you have to be very, very careful at that level. I think still, even at 0.5, I would treat the venous disease first, manage that venous hypertension, and then treat the arterial disease. I will say the changes I make when the ABI goes down is I like compression that has a higher static stiffness index and less external compression, as opposed to like something elastic or semi-elastic where you may have higher external pressures. So I changed the type of compression I'm going to use.
So let me spin it another way. So let's just say the same patient, you know, you do a treadmill test and they're walking ABIs, post-exercise ABI, nadir post-exercise ABI was 0.2.
Yeah, so in that case, I would probably lean towards fixing them first from an arterial standpoint. We don't put most of these folks on a treadmill. So I don't know what they are post-exercise, to be honest. I don't put my 86-year-olds on a treadmill. So I don't know that I have a good threshold for that. I will say if they come back after a week or so with compression and things look worse, your threshold has to be lower, right? If they don't tolerate compression, your threshold has to be lower. But it is very much clinical. I don't know that I have a standard number. I don't know. I'd be interested to hear if
I don't
anybody on the
either. That's the
panel
reason
has
I
a
asked.
standard number.
Yeah.
It's very much a clinical perception.
Yeah, so I think this is a great case, and that's a great question to ask as well. My workup for these patients, it's very multifactorial. If we can determine what the underlying cause of the venous disease is, that's the primary attacking point. So if it is reflux disease that we can address through sclerotherapy, venous ablation therapy, stenting, if this is an obstructive venous disease problem, that's fantastic if we can do something like that. I think that's an important first approach step. When it comes to compression, from my perspective, I always try and look at x-rays and prior angios that were done, and I look at the degree of calcification within that system. The higher level of calcification, the less compression is going to impact the arterial flow. It's very difficult to compress on hard calcified vessels, right? So I'm more apt to do some compression on some patients if they have highly calcified vessels in order to get some of that venous fluid out, because I don't think it's going to constrict too much blood flow coming down. I will always contact my vascular doctors as well, ensure that they have appropriate vessel runoff, right? 3 vessel runoff. Dr. Maier gave his talk. We talk about an angiosomal approach, right? And from an angiosome perspective, we might have single vessel runoff, but when you look at an angiogram and assess it below the knee, we get collateral circulation. And you might have only a peroneal flow open, but it can result in circulation that feeds the pedal arch to the DP, AT, as well as your PT. So peroneal flow could still result in appropriate perfusion to a toe. And I'm comfortable compressing patients in these cases if the appropriate perfusion is there and if we can address that underlying venous disease, but it has to require an appropriate venous workup from the very beginning. And I think that's missed on a regular basis. So the inflammatory component is the other aspect, if we can address that aspect.
Yeah. So compression does a great job managing or helping manage the inflammation. And obviously, once you can start to get some of that edema and control of that tissue fluid, you're also going to increase your perfusion, increase your nutritive delivery, et cetera. That's where I like those, compression that's going to have a more of a static stiffness index, where I'm getting my benefit with compression when the patient walks, when they move, when they do things, without having any true constrictive efforts. And I think that really works best.
Dr. Carman, let me ask you another question. I think, the panel brings up a great question. Treating these patients with mixed disease is challenging, and there's a paucity of data. As far as I can remember, maybe there's more recent data, but Mosti et al. A number of years ago published a very small study, but looking at compression in patients with mixed disease that was helpful. But again, not much data. In the little over a minute left, let me unfairly ask you, any role for intermittent pneumatic compression or other forms of fluid reduction in patients not only with venous disease but mixed disease?
I don't know of any good data to support that. I mean, there's one trial out there that looked at using intermittent pneumatic compression and the benefits on lymphatic flow. So you're going to get some edema reduction. You'll probably get some augmentation from lymphatic efforts with respect to the wound bed at that point. It was not designed for ulcer healing. Yeah. So I don't know that I know of anything for lymphatic flow. I think it's an adjunct, to be honest with you. But if I'm going to put these folks in a good compression, I don't know that it's going to work well over compression. I think it's definitely an adjunct, and it depends on how much swelling there is. The lady I showed you didn't have tremendous swelling. Had that leg had, 3 centimeters of pitting edema, then we may be dealing with a different process. So I think that's a fair question.
Thank you. Yeah, well done.
Can I ask a quick question to the panel? I know getting arterial flow device pumps approved is a pain in the butt, but but there's that meta-analysis from Riaz Bashir and blanking out on the first author. You guys comfortable putting the arterial flow device on, let's just say, a 2-layered Pro4 while the patient has mixed arterial venous ulcers?
I have not used it with concomitant multi-layer compression.
Me either.
Yeah, it's an interesting thought, but I think when you start to throw too many things at one time, it's very difficult to sift it out. So I'll use them independently, but not together. Be a good question to look at.
Yeah.
Okay.
All right, moving along. Do I see, is Dr. Rao out in the audience? I'm the substitute. Substitute, great, okay. Pardon me, I don't have your information here, but we do have a substitute for next case is the option for no option CLTI patient population. Dr. Varghese will be speaking in place of Dr. Rao. Dr. Varghese, thank you very much for your time today. We look forward to hearing your lecture.
Thank you for inviting me. Actually, this is a last-minute substitution, and Dr. Rao was sick, so please forgive me with my slides. So these are my disclosures. So what is no option CLTI? So basically, it's the worst form of peripheral artery disease. The key characteristics include severe ischemia, which is marked reduction of blood flow in extremities, often with the multi-level CTOs and even distal vasculature disease. And another characteristic is definitely non-healing wounds with ulcers and gangrene, failed traditional treatment, either conservative, percutaneous, or surgical. And these patients have an extremely high risk of amputation and subsequent mortality. So this is a very interesting paper while I was going through this, published in JEVT by Dr. Kim and his colleagues. They divided and classified the no option CLTI, and I really like this classification. So basically, type 1 is severe pedal occlusive disease with the no accepted revascularization options available. The type 2 patients are lack of suitable venous conduit for bypass. The type 3 is extensive tissue loss with exposure to viral structures that renders salvage impossible. And type 4, advanced medical comorbidities for which available revascularization options would pose a prohibitive risk for revascularization. And type 5 is presence of non-functional limb. Because we have a chronic limb-threatening ischemia team, and we have a program, and I do see this because the amputation rates are still high in these patients. So basically, the vascular anatomy is absence of a distal target vessel, severe calcification or a heavy plaque, so there will be recoil and early failure with the endovascular therapy, and technically they're desert foot, absence of any named arteries in the foot. These actually contribute 1/5 of the patients with chronic limb-threatening ischemia. So what are the treatment options? Of course, Ebony or below-knee amputation or major amputations, palliative care, and there comes the ray of hope, that is the deep venous arterialization. So I have the disclaimer, I don't do this, so that's why I'm substituting for this talk. So I'll be talking about deep venous arterialization and my understanding about this. So what is deep venous arterialization? So when there is no arterial blood supply available for the distal vasculature, we are diverting the blood from the artery to the venous system. And so the oxygenated blood go and stay in the venous system and the tissues, which will facilitate the healing. So the steps include initially getting access to the pedal veins and put a 4 French, then put a venous catheter. So I'm describing mainly the lymph flow system. And then the venous catheter is advanced, and there is a mesh in the venous catheter that is, usually it is in the proximal tibial vessels, the area of identification of the AV fistula creation. So it is advanced to the venous system, and then it was inflated. Then we go from the arterial system down, and using the needle, we poke from the artery to the vein, creates a AV fistula technically, and then the wire into this mesh. So once the wire into the mesh is closed and dragged down into the vein and outside. So we created a channel from the artery to the vein. So from the arterial system, from the top, balloons will be advanced, and balloon valvuloplasty or arterioplasty will be done. Then subsequently, a biotome will be coming down, will be advanced to cut the valves in the vein, which will reverse the flow from the artery to the vein. So that is the arterialization. So then again, there will be 2 stents placed. One is both are self-expanding PTFE stents placed from the veins from the bottom, and that will keep the patency. So that is the technical aspect of DVA. So this is just describing the lymph flow system and how it is done. So the end result is a permanently bypass unreconstructed arteries, and you can see the oxygenated blood is diverted to the veins into the foot. So what is the data associated with this new technology? This is an upcoming new technology, so I think we are seeing the early results. So the PROMISE one was a prospective early feasibility study done in 2017-2019. It was done in 32 patients. And the ALPS was a retrospective analysis. It was a non-US study. So they also had 32 consecutive patients treated with the lymph flow. So this is the amputation-free survival rate in the PROMISE 1 study and the ALPS retrospective study. So you can see at 6 months, there was 74% amputation-free survival and 70% in the PROMISE study. And at the end of 2 years, it was 59%. Almost similar in the retrospective study. Again, this is only 32 patients. And this was a 24-month survival. And in the PROMISE 1 study, there was 77% survival rate, which I think it is pretty good because these are the patients with the highest mortality in any patients. And I did not show the slides, the mortality of these patients are even higher than many cancer. And even the ALPS study, the survival rate was 80%, which I thought at 2 years is pretty promising. So this was the landmark paper published in New England Journal of Medicine by Dr. Shishbur and his colleagues, transcatheter arterialization of deep veins in chronic limb-threatening ischemia, and this was the PROMISE 2 study. So they have 105 patients in the study, and this is the Kaplan-Meier analysis, and I will come to this in the next slide. So the key findings, actually, to be honest, I have to go through in detail because the statistical analysis is a little complex in the study. So that at 6 months, I'm talking about 6 months, the amputation-free survival was 66%. The limb salvage was around 76%. The survival of this patient at 6 months was 87%, which is still pretty good. The procedural success at 1 month was 77%. The primary patency was at 26%, but secondary patency, which means more assisted, more interventional endovascular procedures done, and was 64%. And the median procedural time was almost 200 minutes, a little over 3 hours. So again, you have to remember, you have to take this data with a grain of salt. This is a very preliminary information. And if you look at any technology which advanced, for example, in a structural heart disease, when percutaneous valves came in, the mortality was very high when we started. So over years, the mortality decreased. So I think we are going to see, and we are going to learn from this. So I think it is a very promising results, even though some people think this is not acceptable. So what are the lessons learned? Again, this is not for everybody. The patient requires salvageable tissue. You have to consider the anatomic consideration, again, with the appropriate donor vessel, at least 2 millimeter. And the DVA maturation takes time. So I had a patient I sent to an outside hospital in UT Southwestern, and he had a DVA. Man, these patients are in pain, and they have to be managed very carefully with the pain medications. And I'm pretty sure the panel, expert people in the panel can comment on this too. So DVA requires 4 to 6 weeks of tissue granulation to start with. You have to understand there will be a lot of edema when we are diverting blood from the arterial to venous system. Need to preserve the native arterial perfusion and manage the pedal loop during the maturation process. So sometimes you have to go and do balloon venoplasty again. So important to monitor the changes in the foot like infection and pain. Absolutely necessary to have a multidisciplinary collaboration. and minor amputation management needed and debridement. Actually, that ends my presentation, and happy to answer any questions.
Excellent. Thank you. Thank you so much, Dr. Varghese, especially for stepping in kind of last minute into a subject that you may not have a lot of familiarity with, but you did a great job. This is really a great procedure. We were fortunate to be part of the PROMISE-2 study, so we've actually seen the results hands-on, and I think it's an opportunity to address a population of patients that otherwise would receive major amputations. So I think it's great you presented that today. We'll turn it over to the audience and/or the panel for questions now.
I have a question. Actually, maybe Dr. Kolluri, Dr. Carman can comment. Beyond just the complexity of the procedure itself, when you're dealing with patients with this severe disease, do you change your medical strategies or your overall management? How do you adjust for these patients in such dire straits?
Yeah, so these are typically your most severe vasculopaths, right? So I think making sure that you have all of your vascular risk factors, making sure they're on high-dose statins for endothelial support. Many of these patients should be on, rivaroxaban 2.5 milligrams twice a day in addition to aspirin, for their cardiovascular risk factor benefits. Past that point, pristine and meticulous offloading, for their foot and protection becomes really important. You can think about if they don't have underlying heart failure, adding some phosphodiesterase inhibitors, things like that. I mean, you kind of throw the book at these folks because no option can really be truly no option. I mean, at least in centers that have the DVA, that's an option, right? Past that point, you've got a lot of other complex patients where you may not even have those options, and that's where Dr. Kolluri has been talking about the arterial flow device and other, tricks of the trade.
Yeah, I honestly don't have anything else to add other than what Terry said, but I do have a question for Brian, because you said that you are part of PROMISE-2. In terms of the wound healing, you have the angiosome concept where we're so, laser focused on, getting the inflow into the target angiosome, right? In terms of the wound healing, when in the post-DVA patients where, the blush goes everywhere, right? So what has been your personal experience in the wound healing? Let's just say it's not in this. Of course, these are desert foots and those type of things. But have you noticed that I wish the DVA was done in another tibial? Do you see what I mean? So
Sure.
Does that happen at all?
Yeah, you mentioned this wound blush concept, and I think for traditional revascularizations, that's what we look for. In these arterialized patients, I believe it's a different phenomenon. You're creating a fistula and sort of recreating a pedal loop, as you saw in one of those pictures. And, by doing that, a lot of the maturation process takes place sort of down the road. It's a 4 to 6 week time period. And you're really not necessarily looking for that wound blush per se, because in a lot of these particular patients, they have significant tissue loss at the distal forefoot, so most of them are undergoing, guillotine or open transmetatarsal amputations. And so what you're really looking for, the hallmarks are sort of what they call breaking through the fortress. And if you kind of see that pedal loop and see sort of perfusion distal to that, collateralization, and or sometimes they say awakening of some of the hibernated arteries to the toes, that's sort of the clinical indicators. We use ultrasound as well as angiography to determine when those patients are matured. Ultrasound is becoming more the predominance. I think taking these patients back for an angiogram is tough to do, from my understanding, from the vascular side. So we rely on specifically PAT scores, pedal acceleration times, to determine when those arterializations are mature. And a lot of it's sort of clinical and anecdotal. If we see sort of granular tissue beyond or sort of proximal to the necrotic tissue, then that's the opportune time to sort of intervene in those patients, generally about 4 to 6 weeks.
I have a question. Let me open it up to the panel. We certainly have identified this concept of reperfusion edema, and I think you see that in these DVA patients for sure. But I think it even extends beyond them, right? We see that in a lot of patients who have infrapopliteal intervention. And correct me if I'm wrong, but I don't think there's great data on the approach to this. So how do you approach this whole problem of reperfusion edema? Is it just gestalt? How aggressive can you be with compression, and to what extent? I'd open that up to any of my colleagues up here.
Mike, that's a great question. When we were analyzing this trial, we came across a couple of wounds with wounds becoming much bigger on the graph, and when we go look at the toe itself is swollen. You're absolutely right. The reperfusion injury / edema is real. The inflammatory cytokines coming in. I explained to the patients that it's almost like a first-degree burn that they're feeling where it's all inflamed. In my close to 20 years of experience now, that's how long it's been since you taught me wound care, by the way. I have had 2 patients with severe reperfusion injury, and we used hyperbaric oxygen therapy. But otherwise, it's, as Terry just said, it stands for time, gentle compression with ACE wrap, and managing the edema is what we do.
Yeah.
Well, I was just going to say we've started using a little bit of a different compression in our clinic. It's a product. It's for the 10,000-foot generic term. It's called Fuzzy Whale. Don't know if you guys have heard of it or used it. It really stimulates the lymphatics without providing a ton of compression, so you don't have to worry about injuring the tissues. And I find in patients with a lot of edema that's not responding to typical compression, if I add that, it helps. And I've actually talked to Dr. Shishabor. I want to add that to our patients with DVA, where we're getting that reperfusion edema, because I think it's going to do a great job of stimulating, mobilizing the lymphatics without causing any additional compression, and it helps tremendously with the inflammation. There's a fuzzy, if you, yeah. No, it's not Smooth Dolphin. No, Fuzzy Whale. But if you, there's a couple of different brand names out there. Happy to share.
I think that's a great question, a great topic. And I think I've seen this happen a lot. I've managed a handful of these patients, whether it be these no-option patients or just a typical revascularization. We get this reperfusion injury. It wakes up a dormant infection that's been chronic in nature. We get a subacute infection that pops up, and it's very difficult to manage. And I think it's important as the wound care provider, whether it be the surgeon, whoever's managing these patients on a weekly basis, to make sure these patients are taking the appropriate medications on a regular basis. Are they taking their blood thinners? Because they forget. They go home and they're not taking their Plavix and aspirin. They're not taking their statins. Have they been set up with the appropriate cardiologist? Are they just put on a 20 milligram statin when maybe they should be set up on 80 milligrams at this point? And it's been missed for a long period of time. And this hyperlipidemic state puts them at further complications down the road. So if we can address the underlying venous pathology prior to the intervention, we can hopefully prevent some of these reperfusion injuries. But I'm pretty aggressive with eliminating the infection, debridement if we possibly can, as soon as we possibly can get these patients into an advanced level of care. But it really starts with a collaborative approach with multiple disciplinaries, specialties with infectious disease, venous, arterial, plastics if you need to as well, your podiatric surgeons, orthopedic surgeons, vascular surgeons, and making sure the patients are aware of what they are dealing with and getting them to buy into this and take care of themselves. If they are not able to do that, it's going to be a tough battle.
Great points. I want to tell one of my experience. Actually, one of my cases in 5-6 years ago. I opened multi-level CTO, and I was showing everybody a case. Hey, I did this in 2 hours, and 3 days later, the patient called my clinic and said, I have severe edema. If he doesn't take care of this, I'm going to the court. So one thing I realized that you have to reassure the patient. So this works. Our revascularization works. And the second thing is I do cheat. If there is an option, I put them on a little bit of Lasix. You have to watch the kidney function, but Lasix therapy, 40 milligram for 2-3 weeks, I think it is not going to kill the patient. You just have to be careful.
Prior to all of my intervention, I always check to see this patient's prior echo and EF, evaluate their kidney function. If we can diurese these patients prior to intervention carefully, that makes all the difference in the world. And I always try and get them into the hospital, get everything under control for a couple days, then go in and operate on them. Don't close your patients right away. There's no rush to closing these wounds. If you do an amputation on someone, leave it open. Let that edema settle down, bring them back once it's calmed down, then close them up. If you rush it, it's going to blow up and everything's going to fail. But if you can diurese these patients safely, 100%. Always ask for that.
And another thing I'll tell you, most of this patient has diastolic dysfunction. There is really good data for SGLT2, like Jardiance, Farxiga, and if you find that reason to put them on, that will cause diuresis and dryness too. Another point to add.
Really great discussion. I hate to cut into it, but I think we're doing great. I think the one thing to remember is that these DVA patients are significantly different. I think we're just beginning to scratch the surface when it comes to management of these patients. So, to be continued. But thank you very much. I will step up as the next presenter. So I'm going to piggyback a little bit off of that DVA conversation, speaking more about fundamentals of wound care post the TADV patient or DVA patient. Again, these are a much different population of patients than we're used to, specifically for the podiatric and orthopedic colleagues, and even for our vascular colleagues who have not had a lot of experience with the DVA patient population. They're handled much differently. My name is Brian Lepow, and I run a private limb preservation program in Houston, Texas called Hope Vascular Podiatry, and so we'll teach you more about that down the road. So if we can move forward, let me grab the clicker here. These are my disclosures. I'm a consultant educator for Inari Limb Flow. I spoke about this yesterday for some of those who attend the lecture, but I think, in this particular population, multidisciplinary care is essential, specifically with this DVA patient population. If you're not working in a multidisciplinary team, it's going to be very, very difficult to manage these patients. I think there's a lot of nuances that go into it. Again, this is new technology, so it requires a lot of buy-in from people, and it's an ongoing thing. Just kind of scrolling through what we like to call our love chat with my vascular surgeon colleague here, and it's a constant process. We, not only talk about these patients on a daily basis, we have now set up independent sort of rounds to sort of reestablish new algorithms for these patients on a weekly basis. We're looking at all of our arterialized patients and independently looking at the specific DVA population of patients to be able to find out how we can do better. So I think that is really essential. I can't emphasize more how important it is. So things to expect in that post-DVA patient is that we've talked about acceleration of healing doesn't typically occur for about 4 to 6 weeks. It's very sort of unnatural for us to think that we can operate on these patients. We have to wait 4 to 6 weeks to intervene, but that's sort of the honest reality, is that we're waiting for these DVAs to mature. It's not that they get a direct revascularization and you can go and operate and take off the dead toe. There is a process of waiting. During that time period, the wound may deteriorate. Again, these are all things that you need to be familiar with and want to educate your patients about. Use caution in any surgical debridement prior to 4 weeks, because you will, technically what's happening when you do this arterialization is that you are creating somewhat of an ischemic event to the distal aspect of the foot. Any surgery you're going to perform, it's going to die back. The really two drivers for early intervention include infection and pain. We spoke briefly about the infection component, and you're right, a lot of these patients come in having significant soft tissue loss of the distal forefoot, necrosis, gangrene, which may appear stable, but once you revascularize them, specifically in these DVA patients, it could be like pouring gas on a fire, and you could see an immediate sort of explosion of infection. And so you want to watch these patients closely, maybe begin them on prophylactic antibiotic, spread the love, and have have infectious disease following these patients as well. It's very important with this population of patients. Swelling is a very common thing that happens. I know we've discussed it a bit here. In this particular population currently, it's very important to manage that, but in a bit of a different manner. You can't compress these patients because you risk occluding the DVA. Generally, the swelling is secondary to that sort of reperfusion type injury that we discussed. Untreated edema, as we've learned, can inhibit wound healing. So we have to find a way to manage those. Currently, in this particular population of patients, elevation is sort of the utmost critical thing that we can do for them. And then mild compression, generally like an ACE wrap, is all that we really need. I know for some that's sort of hard to understand, but in this particular population of patients, I think we have to look at things a bit differently. Layered compression dressing is not ideal for them, and so you have to find a better way to help manage these patients and their edema. I'm interested about this fluffy whale thing. I'd like to hear more about that because that may be a good option for us. Again, in the immediate post-op setting, I think it's also important to mention negative pressure. Negative pressure for me is one of the necessary entities to management of these patients, but again, outside the box thinking for this particular population. I don't apply negative pressure immediately post-op. I usually wait 24 hours because I want to see what the wound looks like. I want to see how well what has happened, sort of what is the collateral damage post-debridement of these patients. You want to make sure you're achieving adequate hemostasis. Contraindication, obviously, to apply negative pressure to a bleeding wound. In this particular population of patients, the pressure settings are set lower than the norm. Generally, 60 to 80 millimeters of mercury is what's indicated for these patients' populations, and the reason for that is that you risk sort of kind of occlusion at the distal aspects of those little, sort of reperfusion in those little venules that have sort of formed post the TADV patient. Proper secure the VAC. I mean, I have seen wounds created by inappropriate VAC being applied, so I think it's really important, specifically that not only are you prepping the site, in an efficient manner, but also making sure the VAC tubing is being protected. These are still ischemic patients, and then they're going to swell post-TADV. And so if you're applying that tubing right on the skin, chances are you're going to develop depression necrosis, and you're going to have another problem on your hand. The other thing to consider is where that sucker goes. I've seen a lot of pressure injuries induced by the little track pad. So again, all these things are important. It's not just so simple to throw on a vac and let them go on their way. A lot of injuries can occur from that. And you have to remember, at least I've learned the hard way, that when we send these patients home, you need to follow up with these patients. Not only following up for their anticoagulant in their postoperative phase, asking about the wound vac. Because a lot of these wound vacs that get, these home vacs that go home with these patients are already pre-calibrated, preset. And so what I'm finding is a lot of these pre-calibrations are at 125 millimeters of mercury, which is contraindicated. Next thing you know, the patient comes back 2 weeks later and the entire distal foot's necrosed, and you wonder why. You look at the VAC, and that's the reason. So you have to constantly be on top of these patients and ensure that they're getting the proper care post-operatively. We'll jump into a clinical case. This is a 63-year-old female, type 2 diabetic, hyperlipidemia, asthma, and GERD. Surgical history included failed amputation bilaterally and a failed revascularization. She was sent to our clinic for sort of a no-option evaluation. We've established a great referral network in our community, and this lady was told she needed a BK. However, she came to us for an option of salvage. So this is kind of how we initially had seen the patient. She underwent a prior TMA at an outside facility and was dying back and really had no options for revascularization at this time point. And so she was brought to us for further revascularization options as well as management of the soft tissue. Typically when we're looking at these patients, there's sort of two different pathways they can go. It's either the flow team takes precedence and does revascularization. That's without the presence of any type of infection that needs to be managed. Other than that, the toe team comes in, does some footscaping, and then they go back to the flow team. Most of these patients, if these wounds are stable, we try to stay away from any intervention. As we talked about, the two drivers for early intervention include infection and pain. Pain sort of is a way to manage sort of the pain is doing sort of a decompression of the forefoot by taking off the forefoot post-TADV patient. And here you can see kind of the pre and post. You had kind of a desert foot on this left-hand side, and now post-arterialization. This is probably about 8 weeks out. You can see sort of some distal perfusion happening, sort of the breaking through the fortress, as they would call it. And now this patient is ready to move forward with sort of surgical reconstruction of the foot. And so typically what happens is what appears dead is not necessarily always full thickness. And so, I think it's important to kind of, sort of gently take a look at what you have. Just because all that looks necrotic doesn't mean you just go and cut proximal to that. Number one, you'll get into the arterialization. Number two, you'd be surprised if you look at sort of the picture on the left. This is now a post-arterialized patient, you can see sort of proximal to that necrotic tissue, there is granular tissue peeking through there. And so what we like to do is called kind of peeking under the hood, and that means just sort of lifting off that eschar. And generally, once we lift that eschar off, tissue is nice and healthy and granular. And you can see here that there was enough really, to salvage pretty much most of that distal aspect of the foot. The more distal you go, the better the chances you have for functional outcomes for these patients. Number one. Number two, you risk not getting into that arterialization. The worst thing you can do is ligate that arterialization. It's going to be a bloody mess in the operating room, and certainly you lose that outflow track. And so it's important that you make sure that you're coordinating with your interventionalist or your vascular surgeon. Where is that proper cut? Sometimes I'll even map it out with my vascular surgeon. Hey, this is where the arterialization is. This is where these collaterals are, the major ones. Don't get near it. And so generally how I manage these intraoperatively or surgically is I'll do the initial debridement, let them sit for 5 to 7 days post-operatively for evaluation and management. Infectious disease is seeing them. We're getting PT going. I tend to have these patients weight-bearing within 24 to 48 hours post-op. You're not protecting your flap. There's nothing that you really need to worry about in terms of management post-op. And I think what we're finding is in these patients, they don't necessarily require what's the standard concomitant procedures, such as a TAL. I think by weight-bearing them early, the musculotendon imbalance is less in this patient population, number one. Number two, there is a reduction in edema and pain in these patients because they are ambulating and the natural things that happen in the body do their job without the patient being non-weight-bearing. Following the open amputation, I'll usually use a skin substitute product. There's various products out there that you can use to your liking. That's also coupled by negative pressure. This is about 2 weeks out. That silicone top layer has now been removed. You can see structures are covered. I'll back them for an additional 1 to 2 weeks, and then they're ready for a split skin graft. In our patient population, we want to get these patients into diabetic foot remission as quickly as possible. So that means we're going to get them covered as quickly as possible. Typically, the average for us in this patient population from the time they've hit our door for DVA to time to healing is about 3 months. And so we want to make sure we kind of fall within those confines. Certainly, there are outliers. I mean, these are no option, very sick, the sickest of the sick patient population. So, it kind of depends what you're looking at. But most, if not all of our patients wind up getting a split thickness skin graft, harvested from the upper thigh. Here you can see that skin graft. We usually apply them, negative pressure for 5 days, that gets removed, and then we let it fully epithelialize. This is about a week out and then about a month out, seeing here. And then lastly, this is kind of where we started and this is kind of where we ended with this patient. We just followed up with this patient this past week, coincidentally. She's now 4 years out and is doing amazing. Really doing awesome. And, this is kind of what it's really all about. We're trying to create functional amputations in these patients. We call it the toe, flow, and go model. Toe being the podiatry, flow being our vascular surgeon, and then go. We want these patients up and walking. There is no sense in performing all this. There's a lot that these patients have to go through. There's a lot of buy-in that's needed from the family, and you want to make sure that these patients are going to have a functional, successful outcome in the end. And just to kind of wrap things up here, in this particular patient population, avoid aggressive debridement early, avoid tourniquet use. Yes, these patients are going to bleed, and they're going to bleed a lot, but you want to be able to see that, ligate those vessels, and make sure that you're properly planning for proper anticoagulants and coagulation during the procedure. Don't do anything too proximal. If you do, you risk running into the arterialization site, which could be very problematic. Avoid primary closure. I would say in 95, 98% of our patients, and we've probably done 150 plus of these, all open procedures, and they will heal by secondary intention. I know it's out of the norm for some of us to get comfortable doing that, but this is how these patients heal the best. We don't close them for many reasons, and we can get into those at a different time. And then lastly, prepare for bleeding. These patients are arterialized. It's venous flow. It's different. They're going to bleed a ton. You make that incision, they're going to bleed a lot. So be prepared for it. And lastly, multidisciplinary care and communication within the team, the family, and every person involved is critical for the success of these patients. So with that, I thank you very much, and I will turn it over to the panel and the audience for questions.
Yeah. Well done, Brian. This is obviously a challenging patient population, beautiful case. 2 questions for you. I remember many years ago when the negative pressure therapy came out and people kind of scoffed at it. Now it's pervasive and used all over the place. Any thoughts, though, or comments, and I don't know what the literature suggests, on continuous versus intermittent therapy? Is intermittent therapy ever used, for instance? So kind of a small technical question. And then beyond that, can you comment a bit on the whole concept of functional amputation? I think that's really important when it comes to limb salvage for these folks. You demonstrate that this one can walk well, and that's obviously with paying close attention to functionality, not just preservation of anatomy.
Sure. So question one, in terms of negative pressure, I don't know that there's a lot of great data to support sort of intermittent versus continuous pressure. What I find sort of anecdotally in the intermittent compression is that it sort of elevates the pain of the patient because the VAC kind of comes on and goes off and comes on and goes off. And I think that suction down provides a lot of discomfort for patients. Now, there is a system, the Veriflow system, which instills sort of antibiotics or fluid of your choice to the wound, and those function on a more intermittent basis. But I can tell you that the pain is significantly higher in that patient population. I think continuous pressure at a lower setting does the job just as fine. And then to your second question, functional outcomes, you know, the thing that I hate to see the most is patients coming in with partial toes or sort of these mangled feet, and you know, you have sort of the hook 'em horn sign from some of these patients. And look, I think that, you know, the doctors out in the communities are trying to do the best to manage these patients, but the reality is these are sick patients, and you know, they're coming to you to walk again. And after being told that they're going to lose a leg, and having a functional outcome, meaning having something that's shoeable, and not necessarily an over-customized shoe. Most of my diabetics and these arterialized patients get an extra depth shoe. They get a carbon fiber gate plate, plus or minus a filler. I had a conversation last night about the filler. I don't always love the fillers because I think sometimes they provide more problems than not. Some people need them for support, others don't. But again, the idea and concept of functional outcome is not to leave these patients with mangled toes, because the reality is that it's just going to be a revolving door, right? If you have a patient that's arterialized, that arterialization, and for that matter, most revascularizations, the patency rates aren't great. And so if you kind of take a toe or partial toe, the reality is that these patients are going to wind up back in your office, you know, bumping the toe, the dog steps on it, they drop something on it, and now they're facing the whole process again. And don't forget, that one necrotic toe on that patient starts a whole stream of events, right? They have to get seen by the vascular specialist, the interventionalist. Then they have to have an ultrasound done. Then they have to, you know, maybe have an intervention. They have to be hospitalized. And so that sort of creates this revolving door for these patients. And the longer these patients are hospitalized, the more hospitalizations that they have, I think the lower the chance for successful outcomes they have.
Brian, that was a fantastic case. I want to get your input on a couple things that I integrate with some of my patients as well. I think that your approach intraoperatively with not using a tourniquet is ideal. I think there's a lot of options that we have available. I know in the OR, I'm always prepared with silk ties. I use hydrogen peroxide on a regular basis just to be able to get good optimization of the field. You can utilize hydrogen peroxide on a regular basis. You can just dilute the field. It's not going to cause any issues. Make sure your dissection is appropriate. Post-operatively, what I do with a lot of my muscle flaps and skin plasties, and in these patients as well, to maintain as much local perfusion as possible, I usually get them set up with pentoxiflin and Viagra, and I'm putting these patients on to get some local vasodilation. It's important during the procedure as well that these patients maintain a good mean arterial pressure. A lot of times anesthesia wants to keep this pretty low during these procedures, right? We want to maintain as much as we possibly can. These patients are sedated. If we can maintain that pressure up at a high level during the procedure, we can maintain good perfusion throughout the case, reduce some of those reperfusion injuries that we talked about earlier, right? So if we can, I like to do some additional medical management post-operatively from those vasodilator components. And from a pain standpoint, my pain control with these patients, I put them on tramadol and gabapentin and Tylenol, and that's it. Mm-hmm. They don't need to be on anything else. You can reduce a lot of the narcotic use as long as you have good, appropriate dissection. But taking that systemic approach, which you do a fantastic job of, I think that was a great case. So I want to get your input on some of those methods.
Look, I think that's all great questions. I think medical management sort of pre and post-operatively is really critical. I, to be transparent, don't do a lot of that. A lot of it's left to sort of the collaborative effort with my vascular surgeon. Most of these patients are on Plavix, aspirin, and Xarelto at various levels, and that's sort of managed per my vascular surgeon colleague. I think, again, it's maybe regional how these patients are treated. So I think it's, in theory, it sounds great. These patients sit on a hospital service, usually have multiple, cardiology and radiology and ID following these patients. So I typically sort of stay away from messing with most of the medications and leave it to the vascular surgeon colleague and or their primary doctor to manage that. So that's great that you do that. Most of these cases for me are done under a regional block. So I will either do a pop SAF block on these patients and or just an ankle block. It's rare, if ever, that these patients undergo general anesthesia. I don't know that that's really necessary for this patient population. I think, I have a handful of cases that really have undergone general anesthesia. And I think that maybe that helps sort of in the long run with these patients with their recovery. And I think they do fine. Sometimes a supplemental block is necessary, but I can usually get away with a sort of a 20 cc block in a ring block fashion, blocking the PT and doing as much as I can, doing an open transmit throughout the duration of that block. And so, yes, I think that, we have to do a better job at sort of thinking about, hey, we're just not sort of the operators of the foot. So I applaud you for getting involved in the medical management because I think that's really important. I don't know much of the data behind that supports that, but I think, a lot of this is real world data, right? And I think unfortunately, that's not always what's best, but I think in the reality of management of these patients, that's what we have, so.
Thanks, Brian. Fantastic case again in a very sick patient population. So we're going to keep moving along here. Next, I'm going to call up to the podium, or lack of podium, Bailey Estes, who's going to talk to us about real-world application of the Wi-Fi classification. Ms. Estes.
All right. I'm glad to be here. My name is Bailey Estes. I'm a nurse practitioner in Abilene, Texas. Today we're going to be talking about real-world application of Wi-Fi classification, why it's very important. A little bit of background about me. I am a nurse practitioner, and I'm very pleased I work with Dr. Varghese up here, kind of representing the more revascularization interventional side of things. But we've started a CLI program within our institution that we've been very involved in, and very fortunate to have our wound care and our podiatry colleagues that help us out, really forming that multidisciplinary team. So I would like to thank the directors of the program really for being intentional in making things such multidisciplinary. So we're going to jump into Wi-Fi classification, talk about what it is, and then go over a couple of cases, which I'd really like some input from the panel as we go through these cases. These are my disclosures. So what is Wi-Fi? Most of the time we think it's that thing that connects us to the internet, right? Gets us more information. It's not exactly that, but it does give us more information as into our wounds that we're dealing with. Gives us something to latch onto to direct us in our care. So it's a risk stratification for patients with threatened limbs, which allows for meaningful outcome analysis, because that's what we're looking for. We're looking for outcomes. We're looking for wound healing. We're looking for patients maintaining their limbs and avoiding major amputations. So what patients do we want to use for this? It's important to have a good patient selection. If we use this on the wrong patients, it can kind of end up just serving to muddy the waters a little bit more, make us a little bit more confused in an already confusing and very cumbersome disease process. So patients with ischemic rest pain, typically in the forefoot with confirmatory objective hemodynamic studies, diabetic foot ulcers, non-healing lower limbs or foot ulcerations of at least 2 weeks in duration, and gangrene involving any portion of the foot or the lower limb. So breaking down Wi-Fi has 3 major components: wound, ischemia, and foot infection. Now, with my background in the cath lab, I really like to focus on ischemia. It's what I know, it's what I'm more comfortable with, but it's just so much more than that. We've learned over the years that revascularization is just one part of a very complex puzzle, and we really need to look into further things like wound and ischemia to really round out the picture and guide our process and how we're going to treat this patient effectively. So there's different grading systems for each component, graded 0 through 3, and you can go through what the recommendations are for each of it, kind of helping negate some of the subjectivity of it. Because a lot of times we see a wound and we think that wound's bad, it looks like a 3, but maybe it's not. Maybe it's not as bad as we think it is. And that's where we really rely on our wound care colleagues to help us out. Because ideally, when we're looking at these wounds, we want them to be debrided to some extent. We want to be able to see the wound bed, get some of the slough off so we can really see what we're working with. Then as we go into ischemia, graded the exact same way. And this is looking at your ABIs, your ankle systolic pressure, your toe pressures, and your TCPO2. In my institution, we typically do the TCPO2. It's what all of our colleagues have kind of decided upon. That's easiest for us to go by. And then finally, foot infection. And it really breaks it down into your local infection and then going out into systemic and severe infections, and really breaks it down to, like I said, to negate some of the subjectivity of it. So we bring those all together. We have our nice little Venn diagram here. Bring it all together to get our scoring. And then we have a further little graph with all our nice pretty colors. And this helps us classify get our clinical stages of stage 1, 2, 3, 4, and even a non-salvageable limb. So that's quite a bit. That's a lot, right? And as busy clinicians, like that's a lot to put together in our day. And if you think, I ain't got time to do that. It's really busy. That's a lot of graphs to go through. So fortunately, there's an app. Love to use my apps for this, and helps me from going through and looking at those kind of confusing graphs there. So let's jump into our first case. I've got an 81-year-old Hispanic male, history of type 2 diabetes, hypertension, and atrial fibrillation. He shows up to the hospital. His podiatrist had sent him. He had a 1-month history of a wound on the right second toe. It was progressively worsening, having some erythema and edema. So he was presented for concern of furthering infection and further workup in the hospital. So we do our workup. We get our Wi-Fi scoring. It's a deep ulceration, but it's confined just to the toes. His TCPO2 test was terrible. In the transmetatarsal leads, we had less than 30 millimeters of mercury, and then only a mild infection. So that gives us a 2 and a 3 and a 1. So we go to our handy dandy little chart, or use the app, which is much easier. Get our 2, 3, and 1. We find that we're clinical stage 4. So this gives us an implication that we're at high risk for 1-year amputation, but also have a high benefit of revascularization. So I'd like to ask my colleagues on the panel, just with this limited information, how would y'all proceed?
Sorry, I missed the question.
You're fine. No, I was saying with this information of high risk for an amputation, but high benefit from revascularization, how would you proceed with the patient in further workup?
Well, I mean, I certainly believe that if there is a potential for attempts for salvage, then you do it. Working with a collaborative effort with your vascular surgeon colleagues, I think is important. So, I think while looking at these clinical stages are important, they help to create sort of a standardized language. I think it shouldn't always be the be-all, end-all. Just because it's telling you that doesn't necessarily mean that you should go to a BK. So I would hope that you would bring in other factors that determine what may be salvageable.
To underscore your teaching point, Brian and I were just talking about how it's cumbersome to go through that chart. So you caught us actually deliberating the chart. So the app is great. We thank you for that. But I think, to underscore previous comments to it, it illustrates the need for multidisciplinary management. I think a classification system is helpful, but clearly it's more than just one provider to handle this.
No, absolutely. I thank you for bringing up that point of having the multidisciplinary team of, it's not just one factor. And even though we have this score, maybe, it just help to guide things. But again, it's not the end all be all.
Yeah, just like any other scoring system, there are downsides to Wi-Fi too. We all may score that infection, cellulitis less than 1, millimeter, whatever, differently. So that would change the clinical stage. The depth, again, in ischemic ulcerations, if there is an eschar over it, what is the real depth? So there are all these downsides, also, I shouldn't say downsides, limitations As Brian said, yes, this gives a good, common language, but then ultimately patient sitting in front of you, you got to be that clinician.
Absolutely, I appreciate those insights.
Bailey,
And-
can I interject with just one question
for
for
it.
the audience then? Given that this is fairly widely utilized, the Wi-Fi classifications, just by a show of hands, in your institution, do you use the Wi-Fi classification? Interesting. Thank you.
Right, so I mean, as I said, it's still complex patient presentation. So we did work very closely with our wound care, and I like to get my wound care's input on the wound staging and the infection as well, because I know that's not my area of expertise. So we ended up taking the patient to the cath lab, did revascularization. He had highly calcified vessels. The anterior tibial and the posterior tibial were, one was a chronic total occlusion, and the other one was subtotal. Had a great revascularization result. For follow-up, we had a pretty good improvement on his TCPO2 test. He ended up, our podiatrist took him and did a partial amputation of the second toe, which is healed well. With our multidisciplinary team, we put him on GDMT. He hadn't been on statins. Of course, A1C is very high, so we're following him up closely with all of the surrounding therapies. So our next case is a little bit more cumbersome. This is also an 81-year-old Caucasian female, CAD, coronary carotid artery stenosis, PAD hypertension, not a diabetic. But she presented with cyanosis of bilateral toes. For the past year, she'd been experiencing increased weakness, claudication symptoms. When we finally got her to come into the hospital to get further worked up, had a terrible PCO2 test, of which normally when we look at this, if any surgical intervention needs to be done, you're looking at not great healing potential and possibly need for an AKA. So we did the workup, no ulcer, no really infection, but the TCPO2 tests were terrible, of course. So when you break that one down and look at it, as far as risk for amputation at 1 year, really said it was low. And then we look at the benefits of revascularization, which was really only moderate. So when our team came together, look at this, it kind of made us a little bit more confused of what to do, because when we look at the patient, we look at the toes that are severely cyanotic, I think there's a high risk, or there's a high benefit of a revascularization. So I'd like to get y'all's input.
Yeah, again, look, I think it goes back to, I think this is just one tool in the toolbox to kind of help paint the picture for these patients. It shouldn't be followed as sort of the gospel for how we manage these patients. So I think while it certainly can help direct, again, conversations amongst sort of the team, and also sort of can be part of that component of care, it should not be the ultimate decision maker for care of these patients.
I'd like to comment just on the physical exam is king. So I know we see some data. I would want to see the physical exam, and then maybe ask my co-panelists here to chime in on non-atherosclerotic causes of cyanosis or ischemia.
Yeah, so that was one of the things that Raghu and I were talking about. I mean, in this lady, in this age, I mean, you also have to rule out things like a hyperviscosity state, multiple myeloma. You have to rule out a lot of other things that may be giving her cyanosis without true ischemia. And I think that also brings up the comment or the question about TCPO2 in these patients, because if TCPO2 is not done well, you're also not getting your optimal data. So all of the tools that we use in the wound clinic to evaluate ischemia or tissue perfusion, I guess tissue perfusion is a better term, have a lot of limitations. And so, you can't underemphasize the need for a really comprehensive evaluation of these patients and not just relying on a number or a score or anything else.
Absolutely. I'm glad that y'all also brought up differential diagnoses, because that was one thing we thought about, especially the presentation of bilateral lower extremities. We thought maybe it's a prothrombotic state, maybe we've embolized some clot from somewhere. So that's kind of what we're looking at as having higher suspicions of a differential diagnosis while continuing to work up the patient. So we ended up, the patient happened to have a CT scan that was done, which showed a 60% calcified stenotic lesion of the infrarenal aorta, We ended up taking her to the cath lab, and she had a 90% stenosis, which ended up explaining bilaterally the ischemia and having the low TCPO2 test. So we ended up placing a covered stent distally and had a marked improvement in our TCPO2. So it ended up being kind of a case where we weren't sure which way it was going to go. It did end up being more ischemic, but it was just one that we found quite interesting. But also equally as important to keep continuing to look at those differential diagnoses and not taking everything just as the end-all be-all. So my key takeaway is going to be for this is use the classification system in collaboration with your multidisciplinary team. And as I said, really do a good physical examination. Download the app. It makes it a lot easier for your calculation, more likely to use it. And practice appropriate patient selection whenever you're trying to use this classification. If you're not using it in the right patient, it can just make you a little bit more confused than you were before.
Bailey, great. Thank you very much. For sake of time, we are a little bit behind. We will hold any additional questions, and we can kind of catch up at the end. Yep. Great job. I'll turn it over to Dr. Maier. He'll introduce our final speaker.
So last but certainly not least, I had the pleasure of meeting Dr. Kolluri when he was a humble fellow at the Cleveland Clinic, and he's ascended to greatness now, holding various academic and scholarly appointments. He's a master physician, clinician, and investigator. So it's a pleasure to introduce my good friend and colleague, Dr. Kolluri, who's going to speak to us on quantifying wounds.
So what Mike is telling you all is that if I screw up, he's responsible. He taught me everything I know about wound care, and Terry, of course. All right, so these are my disclosures, and my talk is quantifying wounds. Really, I'm going to talk, there's less of a takeaway from the exact slides that you see in the clinical world. This is more of how we quantitate ulcers or wounds in a clinical trial setting, but that could be translated in the clinical world as well. So to date, most of the outcomes in the PAD CLI trials are broadly divided either into major adverse cardiovascular events, limb events, or survival metrics, which you see there. Sometimes anatomic success, whether it's binary stenosis or patency or angiographic success. Some clinically driven metrics are also included as secondary endpoints, such as freedom from major adverse events at 30 days or freedom from TLR. These are major adverse events and those type of things. And also QOL, return to ambulation, quality of life scores and all that. And wound healing is now picking up, but all of these patients are pretty sick. They're elderly. You saw Terry's case, 81-year-old woman or whatever, and 5-year amputation-free survival. If I go and tell that person, I'm going to refer you to my interventional partner because your 5-year amputation-free survival is going to be X, they'll give me the stare. Like, when can I get my wound healed and go dance at my granddaughter's wedding or whatever? So wound healing is important, and in the objective performance goals published by Conti et al., they recommended getting photographs and core lab involvement if it's in a trial setting. So in terms of how we measure wounds, we've come a long way. First one is an acetate tracing here, and we'd put it on a piece of graph and then measure the squares in them, and that's how we got the square area. And then we used to use this camera with a circular flash there to get diffuse light to get those pictures. Then the options changed over. When we had the core lab in Illinois, we were using this product called Silhouette, which sort of is a hockey puck kind of thing, and it uses a planimetry mode, which sort of, I'll tell you in the next slide, how it kind of flattens out the wound area. Then there are others too. These are the three we have used. The tissue analytics is one. eCare is what we use majority in our core lab for clinical trials. What it is basically, it's a simple iPad-based or now any iPhone Pro-based based app where you take a picture, and what it creates is this contour based on the macro photography thing. If you have used your iPhone, and if you bring the phone close, and if you have 3 lenses, the Pro, it senses that the macro, meaning very close-up pictures, because it's sensing the distance, and that is taken advantage by this technology to create this kind of contour, and it gives a nice spread of the wound, and then you can stretch it out and actually take the area measurement. If you're looking at bottle at end on with his mouth at its mouth, the area of that bottle inside is not just that mouth, it's the whole of it, right? So that's what this does. It's super easy to do. Despite that, we'll still have errors. Some of the challenges in the clinical trial settings, we've talked about neuropathy, mixed ulcers. These etiology assessment is equally important as much as measuring the dimensions of the wound itself. Non-standardized measurements in trial settings will lead to errors. In clinical setting, these tools are used in several centers, not all of them. How many use wound imaging and automated imaging in their wound centers? Okay, all right. So you do, and then Epic also has this nice trend, and I'm sure others do too, to look at the trend of wound healing. So large wounds are difficult, Rutherford 6. You cannot, you need to have a wound in one plane to get that dimension, otherwise you can't. And as I said, if there is no depth because of eschar, the volume comes to 0, simple, the basics of math. So if you are calculating volume of wounds, it better have depth, otherwise it's 0 volume, meaning it's non-existent, which is weird. So here is what we learned. Life BTK trial. This is 261 patients, 50 trials, 6 countries, carefully selected sites. So the reason I'm putting that up front is for you all to know that in this trial, mixed etiology ulcers, including arterial insufficiency in the Esprit group, was 28%, and in the PTA group, 23%. So significant number of patients are being enrolled into critical limb ischemia trials that are not pure ischemic because of whatever, lack of training, awareness, how an ischemic ulcer looks. And as you can see, there's a breakdown now because we have these sites take a long shot of the leg and then a close-up. This is ischemic, obviously. And when you get a close-up, that's venous, that's a trial patient. And this is clearly a neurotrophic ulcer, maybe in addition to the ischemia. When we did the primary efficacy endpoint, the arterial ischemia only compared to the mixed, see how it is benefited by the Esprit. So when you are able to tease out just from that etiology, you can get very granular in terms of what the device does, what the therapy does, rather than blaming the device or the therapy for perhaps the lack of knowledge of what is ischemic and not. We also noted, I don't have pictures here, but as we're discussing in the mixed etiology ulcers, there's no difference between the 2 groups, as you can see here, between the treatment arm, the Esprit and the PTA. Maybe because the vessels were prepped better, I don't know, but that's a whole other discussion. But when we looked at ischemic and non-ischemic ulcers, there was difference, but it was not statistically different. So that changed my clinical practice a little bit, Terry, because this has been going on for about 6 years now in the making. And now if I see a mixed arterial venous ulcer, I have them walk on the treadmill, even my 80-year-olds. If they can walk on the treadmill even for a minute, and I get a postnatal ABI, I will have them undergo arterial intervention first, and then manage the edema after that. We also have these wound healing over time. That blip you see right there was from reperfusion injury. So that's where we were so granular because we were able to get all that data quantify these wounds and get the information that hopefully will change the thought process. At least it changed my thought process clinically. The challenge is, despite being so objective, is you can see here the focus is actually on the blinds and not the foot. And here they send a picture of a picture, so you can't get a depth or any dimension to it. So, in conclusion, while wound healing is a complex phenomenon, and it's not just arterial flow, we talked about Wi-Fi and all of those things, and because trials have to be pragmatic and you cannot prescribe a specific wound care for whatever reason, whether it's political or the referral pathways, et cetera, adjudication still helps with these etiologies, with standardizing some of the healing assessment process. And large wounds, while they can be challenging, they could still be captured, especially up to Rutherford 5. And finally, there'll be a couple of manuscripts. That data I showed you was reported in the late-breaking clinical trials at Viva, but we're going to publish that. And we're also, for the first time, publish the angiosomal concept in 181 ischemic ulcers that are adjudicated independently by angiographic core lab and wound core lab to actually answer the question if direct flow to that angiosome really works. With that, I'll stop. Thank you.
Thanks, Dr. Kolluri. As per the usual, a tremendous talk and very insightful. Just for my own clarification, could you please just expand the Esprit BTK? I'm not familiar.
So it's basically a scaffold for below the knee artery stenosis. So it's essentially a dissolvable stent, so it dissolves over time. So that is now FDA approved, and it was New England Journal publication too.
Thank you.
Yeah, I had a question for you. So you're utilizing this camera to be able to determine can you explain it a little bit further in terms of the depth of the wound that you're looking at?
Yeah, so the planimetry is an easy way to explain this. So if you want to know the surface area of Mount Everest, you don't take, or we don't take, a picture from a satellite and draw a circle around it, right? We have to actually get the actual measurement by spreading the area flat, right? So the same concept with our wounds, which are the opposite of Mount Everest, right? So there is that contour that these softwares detect. And then there's it almost creates a lid on the top connecting the two. So it gives an average area and not just, where we take a Q-tip and then look at a ruler, right? So it gives the average area and average depth. Initially they used the Microsoft gaming technology. What is it? I'm blanking out. I don't game. For the depth. But then once the iPhones started the Pro with the third lens, which detects the distance itself, when it comes close, it becomes the macro. Sorry, I'm a photographer, so I'm going to geek out a little bit here. So it gets closer, so you can get pictures very close. So that is, the lens and the camera is actually measuring the distance from the object itself.
Gotcha. So you just go through your app and you're able to pull that up.
Exactly, yeah.
So what I utilize intraoperatively and in my post-op patients is I use infrared radar to determine what the perfusion level is, and you can determine based off of warmth and how much blood flow we're getting. So if I'm for early detection of flap failures, or if I'm in the OR and I'm going to go do a flap on a patient, I will do a FLIR imaging, essentially. If I'm not getting a good image, I'm going to put the flap back in place. Right. And I'll bring them back 2 days later, a week later, And once I get a good image and I know that perfusion's there, then we're ready to go. But it's important to watch those patients post-operatively every hour in the OR. When they come back and they follow up with me, I do the same thing. So it's a really cool app that you have that I think would be very interesting to integrate with some of the infrared technology as well.
You're absolutely right. But as Terry said, the laser speckle, infrared, skin perfusion pressures, every one of them that we have tested over the last couple of decades, it works great in the outpatient setting where it matches, the linear regression is close to 1 with toe pressures and TCPO2s. However, once you take them to the cath lab and do the same, it's a scatter plot.
Got it.
And I believe that is because of the reperfusion. Reperfusion and how the cytokines and inflammatory markers, inflammatory mediators change immediately. So in the cath lab, that's the reason there's FlowMet, there's SPP, I forget which is now, the company is non-existent. So there are multiple different companies and technologies trying the tissue perfusion. But once we have a proper one, yes, integrating with the area and objective quantitative measurements like that we're using in the core lab now, would be very valuable in clinical settings. You're absolutely right. Yeah.
It's a really great conversation and a great way to wrap up a wonderful session. I think these imaging technologies are certainly critical in certain settings and really to kind of properly add to evaluation of these patients. With that, I think we will bring this to an end. I want to thank my co-moderator, the panel, and our speakers today. Really a great session. Wish everybody safe travels home if you're traveling and or driving. Please be safe, and we look forward to seeing everybody hopefully next year. Thank you all so much for your time and your attention today. Thank you.